meta-analysis. So to put our results in context, there's substantial uncertainty about the association between smoking and COVID-19 outcomes. As you can see, there's a reduced prevalence in hospitalized patients, but no evidence actually in our study or in our review of reduced infection admission in community studies. The lower smoking prevalence has also been reported previously, but a recent study, which has not been yet included in our review of Oxford Primary Care Network data, showed in fact a lower likelihood of testing positive for current but not for former smokers. We found some evidence that current smoking is associated with greater disease severity, although not necessarily with mortality, and this has also been reported in the previous meta-analysis. However, the interpretation of our outcomes is complicated by several factors. I'm just going to try to run quickly through these before ending. And that is, observational studies and pandemics present really quite different unique challenges when looking at outcomes, because many of these outcomes or determinants of thereof are confounded with smoking status. So we think, first of all, at infection or testing for the disease or testing positive. We know that exposure to the virus itself may very well be related to self-selection in this stage of the pandemic. So initially, only very few people are infected, and this changes across the stages of the pandemic. And for instance, we could also argue that people who travel more, for instance, are more likely to be exposed initially, et cetera, et cetera. And these factors, these self-selecting factors, may be confounded with smoking status that have an impact. Then when it comes to smoking in particular, it might be that because smokers are more likely to cough or produce sputum, that they're more likely to be tested, even though this is really an unrelated symptomatology, which could result in smokers appearing to be less likely to test positive when they're tested. There's also the possibility, of course, that smokers die in the community, don't ever get tested in the first place, and so therefore they're selected out of the sample. And lastly, you can also assume that, or there could be a problem insofar as testing positive might be confounded with smoking status if there's interference with the testing process itself. For instance, if it provides false negatives. Then if you look at hospitalization and this pathway here, of course, access to healthcare itself is very much conditioned on socioeconomic characteristics, which themselves are confounded with smoking status. And again, this is also dependent on the stage of the pandemic, insofar as early on in the pandemic, people may be hospitalized for different reasons compared with later on when the healthcare system may become overloaded. There's also the issue of reverse causality here, insofar as smokers who have particularly bad symptoms may stop smoking because of the disease. And so that is a problem when interpreting analyses and when interpreting data. And there's also this issue of misreporting, that people may feel stigmatized about their smoking when they're hospitalized, they might not talk about it, or poor recording of smoking status, although most of the healthcare records were actually coming from GP records in a lot of the studies. And then lastly, we look at severity of death. This pathway here, as has been proposed, it could be, for instance, that people who enter, smokers who enter the hospital then don't have access to nicotine anymore, and nicotine withdrawal itself could be a cause of more severe outcomes. Of course, we have to have a suitable follow-up in order to work out whether or not something has, whether the end result is severity or death, which has to be taken into consideration. Any analysis in the study. And then lastly, of course, there may also be diagnostic prioritization. For instance, could be imagined that if there is limited access to ITU, that ex-smokers who tend to be older are more likely to have other health problems, maybe less likely to be prioritized for treatment, which again would bias results. So we really need whole population studies, the studies of randomly tested population with sufficient follow-up in controlled environment and with verified smoking status and with appropriate adjustment to avoid any kind of collinearity problems, collider bias, or confounding. And what's also important to remember is that we need to formally evaluate the effects of medicinal nicotine within a randomized controlled trial to avoid confounding by the rather dirty delivery mechanism of smoking, which may mask any beneficial effects, if there are any. And lastly, then given all of this, I think we have limited evidence to draw firm conclusions about the association between COVID-19 and smoking, but we do know the devastating impact of smoking cigarettes. So in the UK, between 0.3 to 1.1% of current or former smokers die each year, and the lifetime premature mortality is about 50+% among continuing smokers. And this compares with a mortality rate of 0.1% of the UK population, even under more pessimistic estimates for COVID-19. So the dangers of smoking far outweigh yet to be proven benefit of nicotine. Last, I would like to acknowledge the two main co-authors who have done the lion's share of this work, David Simmons and Dr. Olga Persky, and also want to thank Professor Jamie Brown at UCL and Spectrum and Cancer Research for their support. And if you want to get access to this review, which is updated this Friday, you can use this QR code here. Thank you.
Thank you, Leon. And just to emphasize to everyone, the slides will be available as a PDF, and Leon and colleagues' rapid review being updated every week and available on the Chaos website. Kamran, I will hand over to you to talk about smoking cessation.
Thank you, Linda. Thanks everyone for joining in. So I'm going to talk about tobacco cessation. Okay, sorry. Yeah, so as you know that a key public health goal within tobacco control is helping people to quit smoking. And I think in the time of COVID-19, a lot of us are asking some key questions. Some of these questions are, I think, we would not be asking if it wasn't for some of the confusion and some of the uncertainty around the data in relation to the association between smoking and COVID-19. But the first thing I think we're wondering is that, has there been a change in smoking behavior? Are smokers behaving differently because of COVID-19? Is it still beneficial to quit, given the data that we've just seen? Should quitting be part of a public health strategy like social distancing and hand washing? And if so, what strategies may help? And yes, if there are any related research questions that we need to answer. But just before I go on to smoking cessation, I want to mention a couple of forms of non-cigarette tobacco use that has got certain peculiarities that I think makes it quite important for COVID-19. So first one is smokeless tobacco, a global problem which is more common, I guess, in Southeast Asia, but includes almost a quarter of all tobacco users. And there is a particular behavior associated with chewing tobacco, which is spitting. And although in India, we've got a legislation which at the moment is prohibiting people from spitting, but because chewing tobacco, people produce a lot of saliva. So I think it's hard for people not to spit. And hence there's a risk of transmission of COVID-19. And very similar to that is water pipe smoking, which is also very popular, and particularly amongst young people. And it's a social activity. So when people go to a shisha cafe, they don't take their water pipe with them. In fact, they use the one that's already been used by a number of people, and hence the whole apparatus acts as a route of transmission for the virus. And it has been a route of transmission in previous epidemics, and it's likely that it could be a route of transmission for COVID-19, and hence certain countries have introduced legislation in relation to that. So going back to quitting, are people changing their smoking behavior? So yes, the evidence is coming in. Quit lines from the US. In the UK, there's been a recent ASH YouGov poll, and there have also been studies of dual users, including cigarettes plus e-cigarettes. So I think people are certainly thinking about quitting. Some people are quitting more and are more motivated to quit. But it's not just in one direction. I think there is certain other factors that are pulling people in the other direction. So in terms of people who are more motivated to quit, or they're more willing to quit, part of that is happening because of the fear factor. People think that if they don't stop, they'll probably catch COVID-19 and it will worsen. People are not finding cigarettes as accessible as before because of the social lockdown in many countries. And of course, because of the economic situation where cigarettes are expensive, affordability could also be an issue. And hence, because of social lockdown, many people are staying indoors. So therefore, where smoking is prohibited in indoor spaces and also unacceptable within homes, that could be a block in terms of people accessing cigarettes. On the other hand, access to cessation support is not as accessible. And of course, COVID-19 and the social lockdown is putting people under stress and causing anxiety and depression, which can push certain people to continue smoke or increase their use. So I think this dual use study is showing both things are happening at the same time. And what's happening in the other parts of the world? So we've been conducting a survey in Pakistan among smokers, and we were lucky to actually have this survey finished just before COVID-19, and then we did another survey just after COVID-19. And in the survey, we found that 15% of smokers might have actually stopped smoking. And if you translate that to the smoking population in Pakistan, that comes to about 2.3 million smokers might have stopped because of COVID-19. And that's just not the full story. Some people have also reduced the number of cigarettes smoked per day. And in this graph, there are two ribbons. So one ribbon, the red ribbon, represents pre-COVID-19, and the green ribbon represents post-COVID. And you can probably see that post-COVID, there's a shift in the graph towards left, which means that fewer people are smoking cigarettes since COVID-19. Is it beneficial to quit in the short term? I think we already know about the medium and long term that it is beneficial to quit. But in the short term, I think the most evidence we have is indirect evidence from surgical trials and studies in other chest infections, that yes, after stopping smoking within days, there are positive effects in the cardiovascular system, in lungs, in oxygen saturation. The immune system starts to recover within weeks, and the lungs starts to recover within weeks. We know that in other chest infections, quitting can reduce the risk of serious complications. And of course, comorbidities, which have been a hallmark of COVID-19, improves as a result of quitting. So yes, there is indirect evidence that even in the short term, quitting would benefit. So should it be part of public health advice? As my previous colleague mentioned, that the overwhelming advantages of quitting smoking, I think, outweigh the potential protective effect of nicotine in COVID-19, especially as we have nicotine alternatives available, I think, in most of the world. The epidemic also provides a teachable moment, and we know that smokers are more receptive and would listen to stop smoking advice if given during an epidemic. And we know that from other respiratory infections that are life-threatening, such as tuberculosis, that people are more motivated to quit than general population. And people need more support due to higher levels of mental health issues. I think they would need more support. So that is the message. I think it should be part of quitting. What strategies may help? I think in this situation, my recommendation would be to use nicotine replacement therapy, along with supported by quit lines, telephone counseling, text messaging services, and web and social media-based services. Nicotine replacement is widely accessible all over the world. We know that it increases quit success by at least 50%. And as we've been hearing, that if it has any protective effect from COVID-19, then we might as well use this form of treatment than any other form. Combining two forms of nicotine replacement therapy, in this case patch and gum or lozenges, is more effective than using a single form of NRT. And I just want to give a shout out for Quit for COVID-19, which has been an excellent campaign run by volunteers who would be otherwise working in a smoking cessation service. And they've been running social media clinics and have been quite popular. So what are the research implications? I think we know about the indirect benefits of quitting in COVID-19, but I think we need to study whether there is any direct benefit of quitting in COVID-19 in terms of both acquiring infection and also in reducing disease progression and complications. And I think the key question that I'm glad that my previous colleague also mentioned is that, is there any advantage of medicinal nicotine in preventing COVID-19 infection? So coming to the conclusions, I think many smokers are making quit attempts and are trying to quit. On the other hand, some are less motivated, particularly because of the psychological mental health issues. Smoking cessation will benefit COVID-19 patients overall, and cessation supported is needed more than ever. And I think we should encourage smokers to quit for COVID-19 with the help of medicinal nicotine and behavioral support. And I think the potential effect of nicotine in preventing COVID-19 needs further exploration. And these are some of the references I've used in preparing this talk. Thank you very much.
Thank you very much, Kamran. That was excellent. And I'll hand over now to Monika Arora.
Can you hear me?
Yeah, I can, Monika, go ahead.
Okay. So I'll need my presentation up. I can't see it currently. Susan, would you be able to show the presentation? I can't see it on my screen.
Okay, so I can see it at the moment. Do you want Susan to control them and we can just say first slide, second slide?
Okay, I can do that. Yeah, Susan, if you can do that. I will open it at my end.
Great. So Susan, if you just take back control and if you can go on to the second slide, Susan. Okay, Monika, we're now on the, we're past the introductory slide and we're on to your first substantive slide.
All right. Fine. So thank you very much, Linda, and apologies. I was seeing the presentation till now, but it has just disappeared. So I will be talking about need to strengthen tobacco control policies in the time of COVID-19. And as the world is uniting to fight the COVID-19 pandemic, it is also the time to strengthen tobacco control policies to protect people at population level, irrespective of whether they are tobacco users or non-users. Also, we have to understand that why we need to strengthen policies at this point in time. Next slide, please. So as we see that WHO right early on when it declared COVID-19 to be a global pandemic, it also issued advisory for the smokers, pointing that they are likely to be more vulnerable to COVID-19 as the act of smoking means that there is more possibility of transmission of virus from hand to mouth. And also it highlighted that smoking products such as water pipes can transmit COVID-19, as Kamran explained in his earlier presentation. So importantly, WHO recommended healthy lifestyle, and one of the measures in the healthy lifestyle, apart from having all the bodily functions work better, was also including boosting immunity, and quitting smoking is a key component of healthy living. Next slide, please. Apart from WHO's advisory on what the smokers should do and about their vulnerability, WHO Framework Convention on Tobacco Control Secretariat also released their statement recently, early May. And this statement from the head of Convention Secretariat that you see on your screen reaffirmed its support to the parties to the convention, realizing that COVID-19 fatalities are higher among people, and also that those with non-communicable diseases are at greater risk. And we all know tobacco is a common risk factor for the 4 main non-communicable diseases. Therefore, it was requested by the Secretariat that they will intensify their support to the parties who are wanting to implement FCTC at this point. Also, at this time, when the tobacco industry is actually trying to come out and provide philanthropic support to the governments, this statement reminded the parties about Article 5.3 of FCTC and how it needs to be more stringently implemented in these extraordinarily challenging times, and how donations of personal protective equipment, ventilator, and other resources may be looked up at this point in time. They also emphasized that apart from other empower measures and FCTC measures, tobacco taxation is another area which governments must look at to provide resource-constrained governments to cope at this point. Next slide, please. So in this slide, I have shown the various tobacco control policies which have been implemented both alongside FCTC and beyond FCTC. and particularly to tackle COVID in individual countries. So various countries realized that COVID is presenting an unusual challenge. And according to their context, they started implementing these policies. In Bangladesh, Ministry of Health and Family Welfare early this week made a recommendation to suspend production, supply, marketing, sale of all kinds of tobacco products in Bangladesh to help fight coronavirus. Similarly, in South Africa, there has been a ban of sale of cigarettes, snuff, hookah pipes, e-cigarettes to protect workers in the entire supply chain. So lockdown actually protected not just the workers working in the industry, tobacco industry, but across other industries as well. Eastern Mediterranean region has already extensively banned water pipes and its use in various settings to be able to avoid COVID-19 transmission. Israel has instituted a ban on all non-essential business operations. Tobacco and smoking products have been included in non-essential services. India particularly has banned not just the sale, but also use of tobacco products, including cigarettes, the local cigarette, which are called biris, and smokeless tobacco during the lockdown. Next slide. So I will present India as a case study here, just to be able to make a point that how multi-sectoral action is instrumental in protecting and bringing about such comprehensive policies. So India has a unique tobacco burden because we have the prevalence of smoking is just 11%, but it is too high in terms of numbers. Even when we say 11%, it is 99.5 million users. So smokeless tobacco use is more of our worry. And 21% smokeless tobacco users above the age of 15 years have been recorded in Global Adult Tobacco Survey. So Ministry of Health, Government of India issued advisories to the states to raise awareness on adverse effects to smokers. Also, spitting in public places was recommended to be prohibited for the reasons as Kamran had earlier explained. So our Indian Council of Medical Research issued an appeal to the general public not to consume and spit smokeless tobacco in public. And this appeal also said that chewing smokeless tobacco, pan masala, and areca nut increases the production of saliva, followed by a very strong urge to spit. Next slide. So states and union territories have power under Epidemic Disease Act, under Disaster Management Act, and they can in fact use Indian Penal Code and the Code of Criminal Procedures to deal with COVID-19. So letters were issued to various states to be able to take necessary preventive measure. And while the states were coming up with their own orders, even the Ministry of Home Affairs, if you see the order on the right, this is under the National Directive for COVID-19 Management. Ministry of Home Affairs from the center made an order which said that spitting in public places, if you just click one more time, you will see this is highlighted for the order under the order for fines. Spitting in public places was actually made a punishable offense with fine, and there should be strict ban on sale of liquor, gutkha, tobacco, and spitting should be strictly prohibited. On the left side, you see a penalty receipt. So you actually see that for not wearing a mask, there was a fine of 100 Indian rupees, and for spitting in public places, a fine of 500 rupees has been recorded on the slide. Next slide. So apart from protecting users, there is also need to protect non-users. Just to check, we are on the slide which says Article 13 of FCTC and its relevance during COVID-19.
Yes, we are.
So apart from just banning tobacco, it was also important to implement other FCTC measures, and Article 13 deals with prohibiting advertising and promotions. And during the lockdown, it was observed that there was a huge increase in the number of people who were looking at streaming platforms. And if we look at the numbers, in terms of this particular report is from US, it was reported that during the first month of the COVID-19 stay-at-home orders in March, the US audience for streaming channel grew by 50 to 60%, and largely the users were children and adolescents who were at the forefront, which means they were seeing more tobacco use exposure on screen. And earlier studies have clearly established that there is a dose-response relationship. So more they are exposed, it is a higher likelihood that they will start using tobacco and become tobacco user, which would ultimately kill these users in their adult life. So similar reports from US have shown that half of the Netflix's original TV series contained smoking and making children vulnerable to smoking. Next slide. And similar studies in India, also recently completed and published in Tobacco Control Journal, actually showed that in India, when we looked at these series, 10 series which were popular among youth in Netflix and Amazon, 70% of the series depicted tobacco imagery. So in lockdown, these imagery are very, very prominent and are making children and youth vulnerable to tobacco use exposure. But in India, there is a law that prohibits this exposure. There is tobacco-free smoking, TV rules and movie rules. None of these series which we had coded and assessed for compliance with the law, none of them complied with the Indian tobacco-free movie and TV rules law. And these series included both foreign production and Indian production. Next slide. So realizing that there have been violations of various FCTC provisions, and realizing industry is using this opportunity to its fullest to make their public image clean, World Health Assembly recently had seen WHO Civil Society Working Group release a statement in which 36 members of this group, next, you will have to just keep clicking as I say next, next. So you see there is an excerpt that I've taken from the statement which mentions that even in the midst of a public health emergency, we see that harmful products, companies such as tobacco, alcohol, and sugar-sweetened beverage continue to spread misinformation and deny the link between harmful effects of their products and COVID-19 to protect their markets. Next. So there was a call to the governments. There were 12 recommendations, but largely saying that conflict of interest be avoided with the tobacco industry at this time. Next slide. Particularly harmful products such as tobacco and alcohol are declared non-essential within the pandemic response with restriction on availability and marketing. Next. And last is engagement with the unhealthy commodity industry is limited or ceased. So just to conclude, I would like to summarize that key tobacco control policy measures which need to be strengthened are continuing to implement the Framework Convention on Tobacco Control, strictly avoid conflict of interest and not partner with tobacco industry even during this time of crisis and when there is need for extra funds at the government as well as at all levels. Next slide. Strictly enforce Article 5.3. Refuse any CSR, the social responsibility offers for various supports. And lastly, restrict access and increase taxes so that tobacco products are unaffordable. And this is one strategy which has been shown to be most cost effective. And at the same time, also the countries which have raised taxes, they have seen that it provides not only more revenue for the government, but will also avoid future healthcare costs and ease the burden on healthcare system. The countries that have banned tobacco sale should continue to restrict availability and ramp up cessation services. Thank you. Stay safe and be tobacco free. Thank you.
Thank you very much, Monika, and I'll hand over now to Tom.
Hi everyone, thanks to the Usher Institute for inviting me to speak on this webinar. My name is Tom Hurd. I'm a research fellow at the Tobacco Control Research Group at the University of Bath, and I'm going to talk about the strategies of the tobacco industry during COVID-19. So as I say, I'm from the University of Bath. We're the research partner in the Stop Partnership, and to say I've got no conflicts of interest to declare. Finally, before I get started, I'd like to acknowledge the Tobacco Tactics team, who have been doing a lot of the monitoring on COVID-19 that informs this talk. So I'd encourage you to take a look at tobaccotactics.org. So I've split the industry activities into 4 areas. First, CSR, corporate social responsibility, then looking at public health and COVID-19 policy interference. Then I'll take a quick look at marketing and end with a comment on the reporting of the smoking, nicotine and COVID-19 research. So as a reminder, where in terms of CSR and where it relates to the tobacco industry, it's a well-recognized strategy in which the tobacco companies conduct activities described as socially responsible to distance their image from the lethal nature of the product they produce and sell, or to interfere with the setting and implementation of public health policies, as described in the guidelines for the WHO FCTC Article 5.3. So during COVID-19, we've seen a spike in CSR from the tobacco industry. Here are some examples. So the images there you can see are from some of the annual shareholder meetings of PMI, Philip Morris International, Altria and British American Tobacco, some of the largest tobacco companies in the world, where they're highlighting their CSR during COVID-19. So you can see that PMI in that top image highlighting their donation of $30 million, Altria $7 million. On the left there, there's some further examples that show some of the focus has been on supply of PPE equipment, for example, in Costa Rica, testing, for example, in Indonesia, and in some cases just cash in Turkey, for example. And then with BAT, the bottom image there is from an open letter from their chief executive, which, as you might expect, focuses on BAT's investment in one of the companies trialing a COVID-19 vaccine. Now, whilst most countries are not in a position to refuse or reject PPE testing kits, much less a vaccine under the strain of a pandemic, it's important to remember that this is consistent with the tobacco industry's tactic of using philanthropy to distract from the harm it causes, to facilitate their access to policymakers and to increase the public trust in their brand through CSR. Even in the case of vaccine research, I think it's important to remember that the investments in these biopharmaceutical companies allow the tobacco companies to appear part of the solution, and it gives them a respectable voice in the scientific debate, and is a broader part of the tobacco industry's business strategy. And that's the same business strategy that leads to over 8 million smoking-related deaths per year, according to the latest WHO figures. So to zoom in a little bit and see where the tobacco companies' motivations lie, in this case, I'm looking at PMI in particular. These are slides from PMI's AGM a couple of weeks ago. So to put some of those numbers in perspective, 30 million donated is a lot of money, but it represents approximately 0.09% of PMI's net revenue in 2019, which is about just over 30 billion. Their focus on hospitals and at-risk populations fails to include that many of those at-risk populations are smokers and those with smoking-related diseases. And then on the right-hand side, the other slide from the same set of slides on their AGM, they highlight their real concerns, and that's largely that consumption is falling during the pandemic, particularly in low and middle-income countries. So we can see that PMI here is worried about the very thing we need to happen in order to reduce the risks from COVID, and that's smokers giving up and cessation, as we've already heard about on this webinar. So I've explored how the industry publicised their CSR efforts. Here I want to show you a little bit how in other settings they're pushing back against public health policy, in particular tobacco control policy, and some of the emergency coronavirus related measures which they view as a threat. So here are a few examples from the last few weeks. First, in Indonesia, we saw PMI, or an affiliate company of PMI, HM Sampurna, HMSP, pushed for an easing of tobacco excise tax payments due to COVID. As we know, tobacco tax is a tobacco control measure amongst the most effective at lowering smoking rates. In Europe, the tobacco industry representatives lobbied for a postponement of the ban of the sale of menthol cigarettes, which didn't work, as we know that came into force yesterday. But that flavouring ban, obviously regarded as an important tobacco control measure, particularly in regard to youth smoking and uptake. And then we also saw opportunistic delay tactics in the US, with the National Association for Tobacco Outlets and ASTRA successfully lobbying the FDA for an 8-week extension on the deadline to apply for authorization to sell certain tobacco products. So we've also seen this policy interference around COVID-19 measures. So in South Africa, which instituted a ban on tobacco products as part of their lockdown measures, we saw legal action against the government threatened by BAT and one of the tobacco associations in South Africa on that tobacco ban. We know that these legal proceedings are now on hold after some government concessions, but that threat remains. And then in Brazil, we saw PMI maintaining cigarette production in a factory there, despite a decree banning non-essential industry manufacturer. Russia and Argentina, similarly, they had industry representatives appealing against restrictions on cigarette production. And in Argentina, actually, production resumed about 10 days ago. In Indonesia, we saw a particularly worrying spread of COVID-19 and deaths amongst workers at a factory which produces cigarettes for PMI, with reports of a slow response to the first patient in that factory. And again, similarly in Nigeria and Zimbabwe, we had BAT accused by employees of a lack of provisions for social distancing. So on to our third area of focus, marketing and promotion of tobacco products. We've seen, especially on social media, attempts to take advantage of messaging around the pandemic response. The images here are from the Campaign for Tobacco-Free Kids analysis of marketing tactics by big tobacco companies. And from that, we can see examples of tobacco companies using the lockdown and stay-at-home advice to promote their brands, such as BAT's branded Glow, which is a heated tobacco product. At the bottom right image there, they're branded face masks worn by Instagram influencers, in this case in Kazakhstan. And we also saw PMI referring to COVID-19 on social media to promote special offers and home delivery on its heated tobacco products. And we saw that across 18 countries. Finally, I'd like to touch on the reporting of the smoking, nicotine and COVID-19 research. We know that historically influencing the scientific debate has been a deliberate tobacco industry tactic through which the industry seeks to influence the research agenda and to divert the issue away from any causal link between smoking and harm more generally. I haven't seen anything to suggest direct links of the tobacco industry to the research so far, but we have seen the selective amplification of some studies by well-known tobacco industry funded allies and front groups. And we've also seen, and I'm sure you've seen, widespread media coverage of some of the earlier studies, which has caused considerable confusion among the public to the extent that the French government had to issue a decree to limit nicotine sales. So I think it's important to emphasize that care is needed. To echo Leon in the first talk, there remains some substantial uncertainty around the associations between smoking, nicotine and COVID infections and outcomes. So clarity in the reporting of these studies and their limitations is really important. And we shouldn't forget that unrelated to COVID-19, smokers are at greater risk of a range of serious health problems, requiring them to be admitted to hospital. So reducing the number of smokers remains a public health priority during the pandemic. And therefore, we need to remain alert as this undermines the tobacco industry's fundamental business interest in the sale and profit from tobacco products. Thanks very much.
Thank you very much, Tom. Thank you. So we've had a large number of questions and I won't be able to cover them all. I'm just going to ask each speaker if they wouldn't mind turning their videos back on. We've got 10 minutes to cover some of the key questions and I've just selected the most popular ones for the speakers. And I'll just ask the speakers in the order in which they spoke. So Leon, we've had a number of questions on vaping. From Richard Roop, Stephen Carter, Dr. Islam from the Tobacco Control Cell and the government of Pakistan. Excellent questions. So can you tell us, should smokers also in the UK specifically, maybe other countries, be advised that they could continue to vape to stop smoking? And are there any risks of vaping that we know about that might be related to COVID?
Well, we in fact do look for studies on e-cigarette use in relation to COVID-19 as well. And as far as I know, we haven't found any studies that have explicitly addressed this issue yet. So there's a dearth of evidence to say anything about it. Irrespective of that, though, obviously, as I mentioned, there's always a concern about people who are currently not smoking using e-cigarettes. And insofar as people agree that e-cigarettes are less harmful than current cigarette smoking, my advice would remain the same, which is basically if you're currently using e-cigarettes, I would probably suggest that you do not stop because you're concerned about COVID-19, because the risk is that you go back to smoking, which will be worse for your health. But I should say there are no studies that we found that have looked at this explicitly so far in relation to COVID-19. And so there's obviously more research is needed.
Thank you. We'll come back to you, Leon, if we have time. So Kamran, an intriguing question for you. I've not noted who'd asked this. Does tracking and tracing activity allow an opportunity that might be overlooked for a teachable moment to prompt cessation in those that are traced?
Linda, can I just, before I answer that, can I just add something to the previous question? So I think the reason I mentioned NRT as the sort of choice cessation treatment is because I think it is part of the essential WHO essential drug list, and it is far more accessible and available. I'm aware that there are some studies that have shown that e-cigarette use might be superior to NRT, and it is for many people preferred method of quitting, particularly in the UK. But for vast majority of smokers in the world, I think it's not as accessible, and hence I think I would still stick by the recommendations of NRT. Sorry, if you can repeat the question again, I think I missed that.
That's a really intriguing one. We're all talking about tracking and tracing, Kamran, aren't we? Might tracking and tracing activity provide an opportunity for a teachable moment for smoking cessation in those who are traced?
Yes, absolutely. I think that's a really good question, and absolutely it does. I think if it becomes part of, which I think it should be part of public health advice, then as we track and trace people and we give them advice in terms of hand washing and social distancing, then yes, asking about smoking and offering them advice and support through a number of ways, I think it's a no-brainer. So yes, it should become part of the tracking tracing system. Thank you.
Excellent. And Monika, a really interesting question for you from Ailsa Rutter, Debbie Barrett, and a number of other colleagues. What about illicit tobacco or illegal tobacco? Is there any tracing or tracking being undertaken, or could that be a future research thing to do retrospectively in the countries that have banned tobacco during the lockdown? So Monika, you're still muted. Sorry. So you're still muted, Monika. So I don't know if you can unmute yourself on the. There we go.
Can you hear me now?
Yeah, perfect. Yeah.
Okay. So in terms of tracking and tracing illicit tobacco is something which has not been done yet in any country or reported. However, countries like Botswana, they have gone ahead and ensured that there was no kind of import that was allowed during this time. So import and export as such has been brought into policies, but in terms of looking at whether there has been an active tracking for illicit trade is something which has not been reported in any of the papers or clippings that we looked at for tobacco-related COVID policies.
Thank you, Monika. It'll be something very interesting to look at in future for those countries that banned it during lockdown. And for Tom, we might have time for more. Really interesting question from Richard Edwards. Looking at tobacco industry CSR, might it part of the strategy be to make public health agencies look a bit mean-spirited, for example, in criticizing them for donating ventilators or other activities?
Yeah, it's a good point. Certainly that forms part of the what's been seen historically from the tobacco industry and their use of CSR in countries. So we are looking to see if there are patterns between where these donations and CSR occurs and where there is pressure on either public health policies or COVID measures in different settings. Historically, that's been the case around tobacco control, so I would not be surprised to see it here. And that's at a country level, but at a smaller level, I think if you are a hospital receiving a large donation of much needed PPE, it is much harder for example, doctors in that hospital to call out anything they're seeing around smoking. So yeah, I think that raises a good point.
And then an additional question is about the quality of research. This could be for Leon, for Kamran, or for others, that is being produced at this time. We're all seeing rapid preprint publications, probably highly suspect in many cases. That might be part of the reason, Leon, why some of the quality issues have arisen in the studies you're looking at. So would anybody like to comment, maybe starting with Leon, on how we address this quality issue and try and improve these things moving forward?
Well, I mean, part of the reason why we've done a review and a meta-analysis is to some degree overcome the problem of biases in individual studies, to see what happens when you combine them. I think in general, though, as I was mentioning as well in the Q&A to Richard Edwards, I think it's important that editorial teams take into consideration that when people make very strong claims about a particular association, that alternative explanations are provided, i.e. Acknowledgement is given to various biases that could occur in this context. And then they have to make a decision as to whether they think that these biases outweigh any kind of interpretation, i.e. is it sensible to come to a conclusion that smoking is protective? As I was mentioning, by the way, there is some good scientific reasoning behind the idea that nicotine may be helpful in this context. I think the problem, though, at the moment is, as I mentioned as well, is that if you're looking at smoking as a delivery mechanism of nicotine, it's clearly confounding with the negative effects that smoking may have. So I think there's good reason to consider nicotine as a possible agent that could be helpful in this context. But the best approach to use there is obviously an randomized controlled trial. And so observational studies have these biases, and we just need to be aware of them when we interpret results.
Okay, if anybody wants to comment on that, that's fine, but I will ask an additional question. There's been a couple of questions on inequalities, which is a huge issue at the moment, and it just is a huge issue, full stop. But of course, all of the panelists will be familiar with the very close relationship between mental health and tobacco use. And given the issues we're seeing with mental health conditions and the challenges people are facing at the current time, I wonder if anybody wanted to comment on that relationship and how we connect the two priorities, tobacco cessation and addressing mental health problems. Kamran, I don't know if you want to start, or others.
Yeah, just very quickly. I mean, I think that a big chunk of smokers in the UK particularly, and I'm sure that's correct for other countries as well, suffer from mental health conditions. And it is quite possible that some of their conditions have worsened during the current time. And at a population level, I think more and more people are suffering from psychological and mental health issues. So I think smoking clearly is an inequality issue, not just on socioeconomic dimension, but also in mental health dimension. And it should be a priority. I think that's one of the things that I was trying to get across in my presentation, is that I think there's more need for support in smoking cessation rather than less. And I think if we want to prioritize one group, then I would definitely put people with mental health conditions at the top.
Thank you. Okay, I think we'll stop there with the questions there. If colleagues would like those answered by the panelists, we will, of course, send those. Are there any concluding remarks anybody wants to make? Monika, is there anything else you wanted to add?
Just on the inequalities side, saying that we all know tobacco use prevalence is high among low socioeconomic status population. And that is where we will also see the greatest disease burden. But with the COVID crisis, especially in countries like India, we are already seeing that it is becoming very difficult for poor people to sustain themselves during the COVID crisis. And in addition, addictions like tobacco and their easy access availability would only multiply these problems for low socioeconomic status population. And that's where population level policies and health promotion approach is very, very essential.
I think that's an excellent note to end on. Thank you very much to all our speakers. If you just stay on the line, I'm going to say a few words about the next few webinars, but thank you again, colleagues. That was really outstanding. So I'm delighted to let you know about the next few webinars that we've arranged. Next week, I'm sure many people will be very interested to hear on the experience of Italy, who have really faced phenomenal challenges during the pandemic. So we have our colleague from Rome who's speaking next week. Following that, for more for the researchers on the line, there's been very important work done in a multinational consortium that's looking at resources and the latest research on COVID. So Callum Semple, professor from Liverpool, will be joining us. And then the week after that, I'm really delighted that we've secured a speaker from New Zealand, who of course are not only aiming to deal with the pandemic, but also eliminate COVID-19 from the country, and that will be in the middle of June. And the following weeks after that, we also have potentially speakers from Latin America. And I'm also now trying to arrange a webinar on overweight and obesity and COVID-19, which again, connecting the NCD and communicable disease agenda. So please join us for these future webinars. Thank you very much to all our panelists and all our listeners again. Just to remind you, it is available on YouTube. It's also available in terms of the PDF of the slides. So do visit the Usher Institute website and pass the link on to your colleagues who've not been able to join. So thank you very much again, and I'll sign off at this stage.